Welcome back everyone to the second part of our EKG lecture series, which will closely follow the outline of our book that is listed here on Amazon. In this video, I will cover the clinical features, diagnosis, as well as the treatment options for coronary artery diseases, as well as the congestive heart failure. So in patients with coronary artery disease, there is a decreased blood supply, as a consequence of which there would be a decreased oxygen supply to the heart. Versus the congestive heart failure, these patients cannot pump the blood out of their heart, and thus there would be accumulation of the fluids inside the lungs and the other extremities of the body. So first, I would like to start with the coronary artery disease, discuss all the features and the treatment options, and then move on to the congestive heart failure next. So examples of coronary artery disease include angina, as well as the myocardial infarction, and these patients generally present with the triad of a substernal chest pain that is worsened with activity but is improved with rest and nitroglycerin. And other associated symptoms may include shortness of breath, nausea, or vomiting. However, not necessarily all patients may present with these symptoms, and in that case it's referred to as atypical or silent MI. For instance, patients with diabetes, patients that are post-heart transplant, as well as females or elderly patients may not present with the chest pain, and rather they may only present with, for instance, cold sweats, shortness of breath, and GI discomfort or nausea. So in the case where they present with non-specific symptoms but no chest pain, this is referred to as atypical or silent MI. And the reason for that is that in patients with diabetes, they develop autonomic neuropathy, as a consequence of which they cannot sense the pain inside their heart. Or for instance, patients that are post-heart transplant, there is problem due to the denervation of the heart, and thus they wouldn't be able to feel any pain in their heart. Now, the reason females and elderly are also listed here is that females are generally living longer than males, and elderly patients, so once females are also getting older, elderly patients are having multiple comorbidities, including diabetes mellitus. So therefore, there has been also an association with being female and being an old person to present with an atypical angina. So just keep that in mind. Diabetes mellitus, post-heart transplant patients, female and elderly, are at increased risk of presenting with atypical angina, and thus you should have a high suspicion index for diagnosing angina in these patients. So the heart vessels that are usually occluded in these patients include the left anterior descending, and this is the number 1 cause of occlusion. The next one is the right coronary artery. This is the number 2 cause. And then finally we have the left circumflex artery, which is the number 3 cause of the occlusion causing the heart problems. So just to go over the anatomy, left coronary artery gives rise to the left circumflex, which supplies blood to the lateral left side of the ventricle. The left coronary artery also gives rise to the left anterior descending, which supplies blood to the anterior 2/3 of the interventricular septum, anterior papillary muscle, as well as the anterior left ventricle. The right coronary artery, on the other hand, it gives rise to the right marginal artery, which supplies the right ventricle. It also gives rise to the posterior descending artery in 85% of the times, and thus the posterior descending artery will supply the posterior 1/3 of the interventricular septum, as well as the posterior ventricles. So as I mentioned, right coronary artery in only 85% of the times gives rise to the posterior descending artery, and these patients are referred to as right dominant circulation. In about 8% of the times, it's the left circumflex that gives rise to the posterior descending artery, and these patients are referred to as left dominant circulation. And finally, in 7% of the times, it's the combination of the right coronary artery and the left circumflex that gives rise to the posterior descending artery, and then that is referred to as codominance circulation. So you would be able on EKG to find out which of these vessels is actually damaged. So for instance, if the left circumflex artery is occluded, it will cause the myocardial infarction of the lateral side of the heart, which will present with the ST segment elevation in leads 1, AVL, V5, and V6. If there is an occlusion of the left anterior descending artery, it causes the ST elevation in the anterior leads like V1, V2, V3, and V4. And then finally, if there is occlusion of the right coronary artery, it will present with the ST elevation in leads 2, 3, and AVF. Now, the way you can always remember how each of these vessels is associated with the ST elevation in different leads is if you know the arrangement of the EKG leads. So here we have the direction of the EKG leads. So as I mentioned, patients that have problem in the circulation of the left circumflex artery, they will have lateral myocardial infarction, which presents in the AVL, lead 1, as well as leads V5 and V6. Patients that have problem with the left anterior descending, it would cause an anterior MI which presents in leads V1 to V4. V1, V2, V3, and V4. And finally, patients that have problem with the right coronary artery, it will cause an inferior myocardial infarction which presents in leads 3, AVF, and leads 2. Alright, now next I would like to go over the presentations of the different forms of angina and myocardial infarction. So just to quickly summarize here, patients with Prince-Meadow angina, there is a temporary vasospasm as a consequence of which there would be an ST elevation, and thus these patients present with a chest pain that lasts for only a few seconds. Since the duration is so short, there won't be any elevation in cardiac enzymes. In patients with stable angina, there is enough blood supply at rest, but it's only during activity that the blood supply is not sufficient for the heart. So therefore, they would have pain with activity, but not at rest. With unstable angina or NSTEMI, on the other hand, there is more severe occlusion, and thus they would present with pain at rest. Both of them can present with the ST depression, which means that there is a subendocardial infarction, but then unstable angina is less severe than NSTEMI. So unstable will have a normal cardiac enzymes, like for instance troponin and creatine kinase, while patients with NSTEMI will have elevated cardiac enzymes like troponin and creatine kinase MB. In patients with STEMI, there is a much more severe myocardial infarction which causes the transmural infarction, which means that the entire thickness of the heart is damaged, and thus it would cause ST elevation and elevated troponins and CK MB. And then finally, cocaine, since it increases the levels of norepinephrine in nerve terminals, it will cause increased heart rate as well as increased heart inotropy while it causes the coronary constriction. And thus, due to the increased oxygen demand, while there is a decreased oxygen supply, patients that are undergoing cocaine toxicity are at increased risk of myocardial infarction. So that was a quick summary of all of these conditions. Next, I would like to go through every one of them in details. So as I mentioned, Prince-Meadow or variant angina, it's caused due to the vasospasm of the coronary artery, as a consequence of which there would be an ST elevation. But then since the duration is just a few seconds, the cardiac enzymes like troponins or creatine kinase MB remain normal. And the two features of Prince-Meadow angina is that it's unrelated to activity, and it's commonly seen in young females. So in young females, it's very rare to present with any myocardial infarction or stable/unstable angina. So if there is a female that is presenting with a chest pain that is unrelated to activity, you should first suspect Prince-Meadow angina rather than the other forms of the coronary artery disease. And then treatment of these patients includes smoking cessation, as well as the medication supply with nitrates, or calcium channel blockers. So nitrates and calcium channel blockers, they prevent spasm of the smooth muscles, and thus it helps with the vasospasm in patients with coronary artery disease. Another example that nitrates and calcium channel blockers are helpful to prevent smooth muscle vasospasm is the diffuse esophageal spasm, for which you would again use the same two classes of medications to relieve the symptoms. Next, we have the stable angina. And with stable angina, there is only a decreased blood/oxygen supply to the heart with activity. So therefore, these patients present with symptoms during activity. For instance, the patient may say, I was lifting the grocery bags, that was the time that started to develop the chest pain, I started to rest, and then the chest pain went away. So rest as well as nitroglycerin relieves the symptoms in these patients. So therefore, for the same reason, since at rest you will not see any EKG changes, what you can do is that you have to either do the exercise or pharmacologic stress on the heart in order to be able to see any EKG changes. So for the exercise test, what you will have to do is that you will make the patient walk/run on the treadmill and then check for the EKG changes during that time. If the patient is bedbound or cannot for any reason undergo the exercise test, then you can do the pharmacological stress test next. And for that, there are different medications that you can use. 1, adenosine. 2, the pyramidol, and then 3, dobutamine can be used. So with dobutamine, it increases the heart rate, and thus there would be increased oxygen demand from the heart at the time, which you may be able to see the EKG changes. With the pyramidol as well as the adenosine, what they do is that they dilate the coronary arteries. And since the diseased coronary artery is already at maximum dilation, by dilating all the coronary arteries, there would be a decreased blood supply to the diseased artery, and thus these patients will again, the heart will be under stress, and you may be able to see the EKG changes. So the type of the EKG changes that you may see in patients with stable angina that have undergone exercise or the pharmacologic induced stress test is the ST segment depression. Because in these patients, since there is a subendocardial injury to the heart, electric charges are going away, and thus you will see ST depression. Another two conditions where you can see ST depression include the unstable angina or NSTEMI. So with the stable angina, with activity, you would be able to see the ST depression, while in patients with the unstable angina or NSTEMI, at rest, you would be able to see the ST depression. And then if the ischemia is more severe, then these patients may present with STEMI, also known as ST segment elevation myocardial infarction. And these patients present with a transmural injury to the heart wall, where the entire thickness of the heart is damaged. And in these patients, since the electric charges are going away from the heart, there would be ST segment elevation. And this is an irreversible condition, while the subendocardial injury is reversible. Alright, so in any case, back to the first example that I gave you, the patient said after lifting the grocery bags, I started to develop a chest pain. The patient comes to the hospital, you do the EKG, EKG is normal. You ask the patient to walk on the treadmill and you do the EKG, this time you see the ST segment depression. So at this point, you diagnose the patient with stable angina, and what you will have to do is that you will have to send them for cardiac catheterization. And so they can either undergo the percutaneous transluminal coronary angioplasty or coronary artery bypass grafting. So the CABG is usually used in patients with 3 or more artery diseases, while PTCA is with 1 or 2 artery diseases. So it's the less severe patients that are being treated with this condition. Next, we have the unstable angina as well as the NSTEMI. So these two are similar in the fact that they both present with the chest pain at rest. And then EKG changes for both can show the ST depression. However, one main difference that can help you differentiate these two from each other, unstable angina is less severe than NSTEMI, and thus patients with unstable angina will have normal cardiac enzymes, while patients with NSTEMI, since it's more severe, there would be more damage to the heart, and thus there would be elevated cardiac enzymes like troponins or creatine kinase MB. And then the treatment options for both of these conditions is the same. You will have to treat them with B MONA. So B goes for beta blockers, which decrease the work of the heart. M for morphine to help relieve the chest pain. Oxygen to increase the delivery of oxygen to the heart. Nitrates, which cause primarily venodilation, thus there would be decreased level of blood that go to the heart, there would be decreased preload, and thus there would be decreased work of the heart. And then you can also give them aspirin. Other medications that you should provide them include heparin, atorvastatin, and then you will have to revascularize these patients with either the PTCA or CABG. So just keep that in mind, that in patients with unstable angina or NSTEMI, you do not use the thrombolytic medications. The next condition is STEMI, or ST elevation myocardial infarction. So this is more severe than NSTEMI or unstable angina and causes the transmural myocardial infarction, which presents with an ST segment elevation. Later on, these patients present with the T wave inversion as well as a Q wave. In a few days later, the ST segment elevation resolves, but the T wave inversion persists, and then a few weeks later, both the ST elevation and the T wave inversion resolves, but the Q wave persists. So once you look at an old EKG and you see a Q wave, you can see that this patient had an old myocardial infarction. So therefore, patients with STEMI present with the ST elevation. They can present with the Q wave, T wave inversion, and there is also elevated cardiac enzymes like troponins or creatine kinase MB. And you should also know that troponin remains elevated for 5 to 14 days, while CKMB remains elevated for 2 to 3 days. And then the treatment options in patients with STEMI include B MONA, which was beta blockers, morphine, oxygen, nitrate, aspirin. You can also give them heparin, atorvastatin, and then for revascularization, you can proceed with either the PTCA or thrombolytics. So you may recall that I mentioned that thrombolytics cannot be used in NSTEMI or patients with unstable angina. However, you can use it in patients with STEMI as long as they are within a 12-hour window since the onset of symptoms. So you should be aware of the microscopic changes and complications that may arise after myocardial infarction. So in less than 4 hours, you do not see any microscopic changes, but these patients are at increased risk of arrhythmia, congestive heart failure, as well as a cardiogenic shock. In 4 to 24 hours, microscopic changes show coagulative necrosis with risk of arrhythmia. In 1 to 3 days, neutrophils will come to the site of myocardial infarction, cause inflammation, and thus they would lead to the pericarditis, which presents with a chest pain that is relieved when the patient leans forward. In 4 to 7 days, macrophages will come to the site, and since they would destroy the cellular structures, they may cause free wall rupture, as a consequence of which it can cause tamponade. It can cause rupture of the papillary muscle, which will lead to the mitral insufficiency. It can cause the ventricular aneurysm, and then finally it can also cause the interventricular septum rupture, as a consequence of which there would be shunting of blood from the left side of the heart to the right heart. And then finally, weeks to months after myocardial infarction, there would be granulation tissue and fibrosis. And these patients are at increased risk of developing ventricular aneurysms, which increases the risk of emboli formation. They may also present with the Dressler's syndrome, which presents with the pericarditis, pleuritis, as well as fever. And then finally, we have the cocaine-induced myocardial infarction. So what cocaine does is that it inhibits the reuptake of biogenic amines like dopamine, norepinephrine, and serotonin in the nerve terminals. So when the norepinephrine accumulates, it will cause the increased heart rate, increase inotropy of the heart, and then it would increase the constriction of the coronary arteries. So therefore, by constriction of the coronary arteries, there would be a decreased oxygen supply, while due to the elevated heart rate and elevated inotropy, there would be an increased oxygen demand. So these patients are at increased risk of developing myocardial infarction, which presents with ST segment elevation and elevated cardiac enzymes. And for the treatment of these patients, what you can do is that you can provide them with benzodiazepine to alleviate the symptoms, and you must also avoid beta blockers. So what happens if you give them beta blockers is that there would be more norepinephrine that would be acting on the alpha receptors, and thus there would be increased vasoconstriction, and it will worsen the MI. So therefore, in patients with cocaine-induced myocardial infarction, you have to avoid beta blockers while you treat their symptoms by benzodiazepines. So just to summarize all the findings, we have different forms of angina and myocardial infarction. In patients with Prince-Meadow angina, there is a vasospasm of coronary arteries. It's a short vasospasm, and thus they present with an ST segment elevation, but since the duration is so short, the levels of enzymes, troponins and creatine kinase remain normal. And these patients can be treated with the nitrates, calcium channel blockers, as well as the smoking cessation. In patients with stable angina, there is increased oxygen during the exercise, and thus these patients will only present with chest pain with activity. And then if you make them undergo exercise, then that's the time you may see the ST depression on EKG. In patients with unstable angina and NSTEMI, on the other hand, you will have chest pain at rest. And once you obtain an EKG at rest, you may be able to see the ST depression in both of these conditions. Unstable angina is less severe than NSTEMI, so they would have normal cardiac enzymes, while patients with NSTEMI have elevated cardiac enzymes. Both of these conditions cause the subendocardial infarction, as a consequence of which there is an ST depression, while patients with STEMI have the transmural infarction, where there would be an ST elevation and elevated cardiac enzymes. And then finally, cocaine-induced myocardial infarction causes similar symptoms to STEMI, elevated ST, as well as elevated cardiac enzymes. Alright, now that we are done with the coronary artery diseases, I would like to discuss the congestive heart failure next. So patients with congestive heart failure have problem pumping the blood out of their systems, and thus they present with the elevated brain natriuretic peptides, which is secreted by the ventricles in response to high blood volume. So since the heart cannot pump the blood out, there would be increased volume of the blood, and thus ventricles will increase the secretion of the brain natriuretic peptide. Also, if you obtain a chest x-ray in these patients, you may be able to see pulmonary edema or the cardiomegaly. And then finally, if you obtain an echocardiogram in patients with systolic congestive heart failure, you would see low levels of ejection fracture. So here I have an example of a Frank-Starling curve, which explains that the force of contraction is proportional to the level of end diastolic volume or preload. So the more you fill the heart, the force of contraction increases, and thus cardiac output increases. So here you can see that compared to normal individual, the cardiac output in patients with congestive heart failure have significantly decreased. So medications that can also cause similar decrease in the cardiac output include beta blockers, as well as calcium channel blockers like diltiazem and verapamil, so calcium channel blockers. Exercise as well as sympathetic stimulation can increase the work of the heart, and then finally we have the normal here. So one medication that can give these patients with congestive heart failure to improve the work of the heart is digoxin, and I will explain that later during this video. So there are two forms of the congestive heart failure, including the systolic congestive heart failure and diastolic congestive heart failure. So in patients with systolic heart failure, there is decreased contractility of the heart, And thus on echocardiogram you will see a decreased ejection fraction. Once you listen to these patients, because of the dilation of the heart, you can hear the S3 heart sounds. An example of the causes of systolic congestive heart failure include, for instance, myopathy or myocardial infarction. In patients with diastolic congestive heart failure, on the other hand, there is problem with the ventricular filling during diastole. So for instance, in patients that have undergone myocardial hypertrophy, which presents with an S4 heart sounds, there's problem with filling the heart, and thus these patients will have low blood volume that is being pumped out. Other causes include the restrictive cardiomyopathy, like for instance amyloidosis or sarcoidosis, and these are the other examples that are causing diastolic congestive heart failure. So the clinical symptoms of these patients include dyspnea. So since they cannot pump the blood out of the heart, the blood keeps on accumulating inside the lungs, and thus it would cause pulmonary edema. And you can relieve some of these symptoms by giving these patients furosemide to get rid of some of the fluids. They would also present with orthopnea, and orthopnea means that patients present with shortness of breath upon lying down, and thus these patients usually pile a few pillows under their head at night before sleep to prevent orthopnea. They may also present with the paroxysmal nocturnal dyspnea, where the patient wakes up 1 to 2 hours after sleep due to shortness of breath. Since I explained that these patients cannot pump the blood out, there would be increased fluids that are accumulating inside the lungs, and thus you may hear crackles at the lung bases, and this is usually seen with the left-sided heart failure, while patients with the right-sided heart failure usually present with the pitting edema of the lower extremities, ascites, and the jugular venous distension. Now, there are medications that you can use to increase survival in these patients, and here I have provided you with a mnemonic for that. So these medications include ACE inhibitors, beta blockers, and spironolactone. So ACE inhibitors, beta blockers, and spironolactone. So what the ACE inhibitors does is that it causes both the vasodilation, which decreases the afterload, and it also causes venodilation, which decreases the preload. So by both of these mechanisms, ACE inhibitors will decrease the work of the heart and increase survival in these patients. Beta blockers, they would inhibit the left ventricular remodeling, and they would also decrease the renin secretion in these patients, which causes vasoconstriction, and thus beta blockers also extend lifespan in these patients. And finally, spironolactone inhibits the adverse effects of the aldosterone on the heart. One other point I would like to mention here is that if a patient cannot tolerate ACE inhibitors, then what you can do is that you can provide them with a combination of a vasodilator and venodilator to do the same effects. For instance, you can provide them with hydralazine mixed with nitrates. And hydralazine causes vasodilation to decrease afterload, while the nitrates decrease the preload by causing primarily venodilation. In addition to these medications, there are other medications that can be used for symptomatic treatment of patients with congestive heart failure. So again, these are symptomatic treatment. They do not extend lifespan. An example of these medications include Digitalis, for instance. So what Digitalis does is that it inhibits the sodium-potassium ATPase, as a consequence of which sodium will accumulate inside cells. Therefore, there would be less work of the sodium-calcium exchanger, and next calcium will accumulate inside cells and causes increased inotropy. Now, the other application of digoxin is also in patients with atrial fibrillation. And digoxin works through a different mechanism for patients with atrial fibrillation. What it does is that it increases the parasympathetic tone via the vagus nerve, and thus it decreases the conduction through the AV node. And thus is also used for the treatment of patients with atrial fibrillation. However, as I mentioned earlier, digoxin while it can be used for the symptomatic treatment of patients with CHF, it does not extend lifespan in these patients. There are also some serious side effects that are associated with digoxin, and you should be familiar with those. So all you have to do is memorize this image, the image that I've provided here. So you can see there's a yellow toilet, the patient is throwing up, and there is vibration all around it. So the side effects of digoxin include yellow vision, nausea and vomiting, and arrhythmia. So yellow vision goes for yellow toilet, nausea and vomiting, you can see the patient is throwing up, and arrhythmia for all the vibration around it. And then finally, the other medication that can be used for symptomatic treatment of patients with the congestive heart failure is furosemide or water pill. And what it does is that it gets rid of excess fluid in the body. So if a patient, for instance, that have congestive heart failure presents to the hospital with shortness of breath, you take an x-ray of the chest and see that there is pulmonary edema in these patients. What you can do is that you can give them furosemide to get rid of some of the fluids in their lungs, and that helps them with the symptoms.
Next, I would like to discuss the role of EKG in diagnosis of heart failure. So EKG is not very specific in diagnosis of heart failure. As a matter of fact, in patients with preserved ejection fraction, EKG could be normal. And in patients with reduced ejection fraction that EKG is abnormal, the findings will be all over the place. So again, the findings with the EKG is not very specific. For instance, in these patients, you can have atrial fibrillation, you can have bradycardia, you can have tachycardia. There could be broadening of the QRS interval. There could be myocardial ischemia, first-degree heart block, and so on. So like I said, EKG finding, while it could be abnormal, it's not very specific for diagnosis of congestive heart failure. So then what tests can be used for diagnosis? So number one, we should always rely on our history and physical diagnosis. That's still a very important aspect of any diagnosis that we do. So for the heart failure, what we should look for is for signs of excess fluid accumulation. Like for instance, are these patients having dyspnea, which is shortness of breath, or are they having orthopnea, which means that they have difficulty breathing while lying down. Other signs include, like for instance, fatigue and weakness and so on. Echocardiography, while it's an excellent test that can help us identify the potential causes of heart failure, like for instance, is there left ventricular systolic dysfunction, or is there left ventricular diastolic dysfunction? So while it could help us with identifying the cause of heart failure, echocardiography by itself cannot confirm the diagnosis of heart failure. Same goes with natriuretic peptide. So natriuretic peptides are hormones that help regulate the intravascular blood volume as well as the vascular tone. So their level will be elevated in patients with heart failure in order to compensate. However, natriuretic peptide, while its level is often elevated in patients with heart failure with reduced ejection fraction, in patients with heart failure with preserved ejection fraction, the levels are normal in a substantial number of these patients. So again, natriuretic peptides can help clues to the diagnosis of heart failure by its elevated level, but it's not exclusively elevated in all patients. So then we move on to our gold standard testing, which is the hemodynamic testing. So basically this test will assess the cardiac filling pressure at rest and exercise to help make or exclude the diagnosis of heart failure. And like I said, this is the gold standard. All right, and so that concludes our discussion. Thank you all for listening. I hope you found this lecture series helpful, and good luck to you all.